Okay, good morning, class. Excuse me.
Good morning.
We are going to, I have an announcement. Your quiz, you will be having a quiz, but because this is only a one-time deal, this is not going to be for the midterm and final, but because a pharmacology test quiz is coming up on Tuesday, you would also be getting your anatomy quiz on Thursday. But for the first set of quizzes, I want to ensure that you got settled in with the pharmacology. I'm going to give you a take-home quiz. You're going to get it emailed to you. So you can then do it at home, and it's open book. All right, it's a take-home quiz in this course. So you will get that quiz mailed to you after the pharmacology exam. So this Tuesday, for those of you who are taking the pharmacology quiz, you can expect the anatomy quiz to be emailed to you, and you'll have to have that back to me the following day, Wednesday, by 5 p.m. So I'm giving you over a day to do that quiz. All right, that's not always going to be that way, because at the end, especially with midterm finals, everything's got to be that week. So, but since these are difficult courses, I'm trying to make sure you get settled in the pharmacology. I'm going to give you the take-home quiz for this course. It's stuff you could do. You could probably do it in about an hour and a half. The whole thing. It's mostly diabetes, pancreas, and some general concepts about the endocrine system. So it is not an overwhelming quiz. So you'll have time to do that. And I'll remind you of when you're taking the pharmacology quiz. For those of you who are not taking pharmacology, you're locked out. You got a take-home quiz for your first quiz in this course. All right, that's all I'm going to say about tests for right now. We're going to do move to our next gland. We are going to do, well, before we do our next gland, let me do one complication of diabetes, because you're going to get hit with this, and that is called diabetic ketoacidosis. So before we move to the adrenal gland, there'll be no adrenal gland on your quiz. The adrenal gland is going to be on your midterm. So once again, we pretty much completed everything with your quiz material for this class. It's in your notes, and if you have to look up something, you can look it up readily in a book. I did mention diabetic ketoacidosis before, but I'm going to do it again. So you've got to be familiar with this for the quiz and down the line. It's a fairly common complication. Diabetic ketoacidosis occurs usually in type 1 diabetics. So it's usually in type 1 diabetes mellitus. This is an acute complication that, if not treated, can lead to death. So you're going to get questions on it in MedSurg and NCLEX. And this is what happens is this consists of the triad. Well, before I even give you the triad, this is a type of metabolic acidosis. forewarning you, when we get to blood, we're going to do the adrenal gland today, and then the next gland will be thyroid, parathyroids, and then the pituitary. Then we're moving right into blood. So this is a type of metabolic acidosis. We will review blood gases because you're going to get hit hard with them in med-surg, and students typically are having problems with that. So we'll review it again for you when it comes down to the blood. But it's a type of metabolic acidosis. So metabolic acidosis is a general term. There are many types or examples of metabolic acidosis. One is diabetic ketoacidosis. And the triad of diabetic ketoacidosis the first is hyperglycemia. The second component of diabetic ketoacidosis is, of course, ketosis. Once again, OSIS means a condition of or a state of, and of course ketones, so this is a state of having excess ketones, and this is due to increased ketone bodies.
Professor, I'm sorry to interrupt, but a couple of students said they're waiting to get in.
They're waiting. I can't get them in. They're gonna have to retry.
Okay.
Okay, they're gonna have to retry. Okay, and the three ketone bodies are, remember, always got to remember them. And we already gave you the ketone bodies, but I'm going to give you two again. You know, on your quiz, I'm going to ask you the ketone bodies because I mentioned them last week. So these are the three ketone bodies. And if you recall, for any test, it's acetone that produces this fruit-like odor on the breath. And so the patient actually has this. If they are in diabetic ketoacidosis, very often you can smell this fruity odor on their breath, and that's due to acetone. This is a volatile substance, means it's changed to a gas. The patient, when this chemical gets to the lungs, it's actually breathed out. Every time the patient breathes out, you can smell the gas. So that's the ketone bodies. And the third one is, of course, acidosis. And of course, remember with acidosis, that's a low pH. and the patient is in acidosis. So what happens with this is that remember the insulin enables the glucose to enter the cell. When you don't have the insulin, glucose can't be used for energy. So I'm going to erase this. So once again, these are the ketone bodies. It's these ketone bodies can be utilized for energy. Okay, so it's important that we all we all utilize ketone bodies for energy. So our bodies make ketone bodies in a small amount, and our cells can use them for energy, except the liver. Liver makes them, but the liver doesn't use them for energy. But the brain, if it needs it, can use ketone bodies for energy. So, but they're kept at a certain amount. When they become too high, you develop ketosis. So ketosis is a state of excess ketone bodies, and these are the ketone bodies. So the reason this develops is, if you recall, insulin normally decreases, and this is blood glucose, and insulin also decreases ketogenesis. It doesn't stop it, it just decreases it into the normal, make sure it stays in a normal range. So insulin has many functions, which you're aware, but this is two of them: to lower blood glucose and to also to decrease ketone body formation. Glucagon does the opposite. Glucagon will increase blood glucose and increase ketogenesis. So these are what the hormones do normally. But when a patient develops diabetic ketoacidosis, which is usually in type 1 diabetics, the problem arises because there's a deficiency of insulin. So what happens is, in this scenario, with diabetic ketoacidosis, you have decreased insulin, and increased glucagon. So this is what takes place in diabetic ketoacidosis. So when the body doesn't have insulin, it can't use the glucose for energy. So what is going to happen? The body is going to start to make more ketone bodies for energy. But it starts to make too many ketone bodies. So because patient doesn't have insulin, the body says, hey, I need energy. You could have all the glucose in the world, but you can't use it because there's no insulin to get it into the cell. So therefore, you have all this glucose in your blood, the body can't use it. So the body has to switch to another fuel source, such as fatty acids and ketone bodies. So this is what happens. Now watch what happens with insulin, because they'll ask you this on the NCLEX and stuff. When you have low insulin levels or not enough, say you're under stress, you're a type 1 diabetic, and you're not taking enough insulin, just remember what insulin normally does. Normally insulin decreases blood glucose and decreases ketogenesis. So what's going to happen with this? You're going to have hyperglycemia. There's the first component of our triad, which is groups of three, of metabolic acidosis. Next thing is insulin decreases ketogenesis. So if you don't have enough insulin, you're going to have an increase in ketogenesis, increased ketones. There's your ketosis. So by having a lack of insulin, you're going to have the hyperglycemic ketosis. Now look at glucagon. If you have elevated glucagon levels, then you're going to have increased blood glucose. And there you go, your hyperglycemia again. And if you have elevated glucagon, you're going to have, once again, what does glucagon normally do? It increases ketogenesis. So you're going to have increased ketosis. So what happens in diabetic ketoacidosis? Your insulin levels are low and your glucagon levels are high, and this is the end result in the red, and that produces the hyperglycemia. The ketosis, the ketone bodies also contribute their acids. The acetoacetate and the beta-hydroxybutyrate are acids, so they go up, so of course they're going to produce acidosis, which once again is a low pH here for pH. A low pH, that's below 7.35. Remember, the normal arterial pH is 7.35 to 7.45. So this is the triad of diabetic ketoacidosis. Typically the blood sugar could be 300, 400, and if this is not treated, this is what used to kill people years ago before the discovery of insulin. Insulin was actually occurring on the 100th year of insulin and of the discovery of insulin in 1921. And before that, people would go into acidosis all the time because there was no insulin to treat diabetics. So they would die from the complications of diabetes. One of them was diabetic ketoacidosis. So this is an acute complication of usually type 1 diabetes. And here is the general mechanism. The body, once again, has deficiency of insulin, the body needs energy, so the body shifts to making ketone bodies to provide the energy. So the treatment for this, so this is the basic premise for this. I'm going to do that. I'll just mention the treatment quickly. And I'm putting red here because you should remember it. When I do pH again problems, I'll go back to it, but I'll put it in red. A key point, if you recall from Anatomy 1, in metabolic acidosis, you have the respiratory system compensates. You'll have, in metabolic acidosis, you'll have a respiratory compensation where there's going to be, patient's going to start to breathe. They don't do it on purpose. This is stimulated by, it stimulates the respiratory center. There's an increased rate and depth of breathing. The patient's respiratory rate goes up very quickly. That's a compensation for metabolic acidosis, and since diabetic ketoacidosis is a type of metabolic acidosis, you'll see an increase in the respiratory rate. This is called Kussmaul's breathing. Named after Kussmaul. And so when you hear Kussmaul's breathing, you're going to, in med-surg, be exposed to all sorts of breathing patterns. These are abnormal breathing patterns, and they have different names. So one breathing pattern, which is called a compensatory pattern, is called Kussmaul's breathing. It's named after the doctor that identified it. And Kussmaul's breathing occurs in metabolic acidosis. So in a patient with diabetic ketoacidosis, once again, which is a type of metabolic acidosis, you'll very often see Kussmaul's breathing pattern. The patient's respiratory rate is faster than usual. This is to compensate, to try to bring the pH up. And we're not going to, as I said, we're not going to do all that PCO2 stuff now, but we will do it later on in this semester. All right, so when do you see Kussmaul's breathing pattern? Once again, in metabolic acidosis. And since, once again, diabetic ketoacidosis is a type of metabolic acidosis, you're going to see it. All right, so the treatment for this will keep simple, just so you know. You'll be getting this in your med-surg. But the treatment is, of course, this patient's going to be severely dehydrated, so you're going to give IV fluids. Yeah, we're not going to worry about the types right now. But another key component of this is you have to correct the acidosis and the ketosis. So you're going to give IV insulin. And the only type of insulin you can give IV, intravenous, is regular. Now remember that you're giving insulin, so the insulin you're giving for two reasons: to correct the hyperglycemia and to correct the ketosis, to stop the ketone body production or to slow it down. So once the patient's blood sugar gets to about 250, 200, 250, depending on the hospital protocol, you're going to have to put up a 5% dextrose. You're going to have to add dextrose to the IV fluids. Otherwise, the patient's going to start to develop hypoglycemia because you're giving the patient IV insulin. So it's very important to monitor glucose levels closely. Because as that blood sugar starts to come down, there'll come a point where it starts to drop dramatically, and now you went from a blood sugar of, say, 400, 500, starting to come down. It goes into the normal range, which is what you want, but all of a sudden it plummets into the hypoglycemic range, which is what you want to prevent. You don't want to go from hyperglycemia to hypoglycemia. So you will have to monitor the glucose, and as soon as that patient's glucose level hits between 2 and 250, you're going to keep giving the IV insulin, but now you have to add glucose to the IV solutions. And the reason you do that is because if you don't add glucose to the IV solutions, when the sugar hits a certain level, the patient's blood sugar is just going to drop because you're giving them IV insulin. So they might ask that on the NCLEX, and it's a very possible question, and I know they're going to cover it for you in Med-Surg, but at least you got it here, so you'll have some idea what they're talking about in your Med-Surg or your nursing professors. Another thing you're going to do is, of course, you're going to monitor, you're going to do electrolyte replacement. So, of course, this patient's dehydrated and such because of the high glucose. The hyperglycemia is going to cause an osmotic diuresis. Okay. For your notes, I'll write it. Yeah. So this patient, remember what I mentioned, osmotic diuresis, this patient's high glucose is going to cause the patient to go to the bathroom and urinate a lot. and they're going to become dehydrated. So you want to replace not only the IV fluids, but you're going to want to replace electrolytes. And you replace all the electrolytes but one big one. You must provide potassium, because if you remember, one of the things that there are a few reasons why the patient's potassium is going to drop. But one thing that insulin does, besides lowering glucose and lowering ketone bodies, insulin causes potassium to enter the cell. If you remember from pharmacology, and we did the potassium problem, one of the treatments for hyperkalemia is to give insulin and 5% dextrose. That causes potassium to enter the cells, and therefore the patient's potassium in the blood is going to drop. So when you're giving IV insulin to correct this, even though the patient's potassium level might seem, when you first take it, is normal, it's not going to stay that way. It's going to drop all of a sudden because you're giving IV insulin. So therefore, you must give potassium, because potassium is one of the first electrolytes that you're gonna drop. And do you replace sodium? Of course, but potassium, because of the administration of insulin, it's going to drop. So the potassium might seem to be normal at first, but don't be tricked into that, because you wait a half hour you retake the blood, now they have a very low potassium. So very often the physician or the nurse practitioner will order potassium, even if the patient's potassium is normal, because the patient's getting IV insulin and the potassium is going to go down. Okay, so this is a general scheme. This is a big deal for MedSurg and NCLEX, that's why I covered it. And I didn't go all into the signs and symptoms. I did some of the triad, I did the treatment, and I gave you Kussmaul's breathing pattern. So that's all I'm going to say about diabetic ketoacidosis. That's one of the complications of diabetes. All right, insulins and stuff I do in, of course, pharmacology and some of the problems that are associated with insulins and the different types of insulins. All right, we're going to erase this. And once again, this is being taped, so you will get this lecture later this afternoon once it's edited. I couldn't get those people in, they were locked out. I couldn't get them in from this side, so I don't know what the issue was. But everybody will get the taped, this is all, of course, I tape all my lectures, so you'll get this sometime this afternoon or this evening. All right, we're going to start the adrenal gland. Okay, so we're done with the pancreas because we're doing the endocrine system, so I did not do the exocrine component of the pancreas. But we're going to do the adrenal gland, and it's actually two of them. And the adrenal glands, they sit atop the kidneys. The adrenal glands, very important point is they, of course, participate in a endocrine axis. And the endocrine axis, if you recall, we actually did one when we did the renin, angiotensin, aldosterone axis. That's another example of a axis which involves several organs and glands that operate through feedback mechanisms. So this is another example. This gland belongs to an endocrine axis, and you're going to have to know that the endocrine axis, I'll put here and then I'll write it here a different way. The axis is called the axis is called the hypothalamic pituitary adrenal axis. So this consists of three glands. Well, the hypothalamus has endocrine function. The pituitary is an endocrine gland. And the adrenal, of course, is an endocrine gland. So this axis consists of three endocrine or hormone secreting organs, and the hypothalamus releases hormones that will influence the pituitary. The pituitary in turn will release hormones that will control the adrenal gland. And then, of course, the adrenal gland, which is the last part of the axis, will release hormones into the blood. So this is called the hypothalamic pituitary adrenal axis. You're going to hear all about it. You're going to give medications that can mess around with this axis. So put this another way before we continue with the adrenal glands. The adrenal gland, I apologize, the hypothalamus, the first part of our axis, is the structure in the brain. It's part of the diencephalon, which contains the thalamus, the hypothalamus, the subthalamus, the epithalamus. The hypothalamus has loads of functions, not just secreting hormones. So the hypothalamus is where our thirst center is, where our hunger center is. The hypothalamus monitors the osmolarity of our blood. The hypothalamus controls our body temperature. So the hypothalamus is a very, very important structure in the brain, in the diencephalon, that part of the brain. it releases several types of hormones. One of them is called CRH, corticotropin releasing hormone. That's going to go to the pituitary gland. Specifically the anterior lobe of the pituitary gland. So there's our hypothalamus. It has cells that are going to release the hormone CRH. This will then travel to the pituitary gland, and that will stimulate the pituitary gland. This hormone CRH will stimulate the pituitary gland to make another hormone. That is called ACTH. And you're going to hear loads about ACTH in nursing. ACTH, adrenal corticotropic hormone. This comes from the pituitary gland. This is going to go to, it's going to enter blood, it's going to go to the third part of our axis, the adrenal gland. More specifically, the first, the adrenal cortex. So I'll draw the adrenal gland momentarily. And what this hormone will do from the pituitary gland is going to stimulate the adrenal gland to make and release hormones. So the adrenal gland will now release a hormone called cortisol, and we're not going to do them all. We're not going to have time. This is not a chemistry course. And a hormone called aldosterone. These are very, very important adrenal gland hormones. Cortisol and aldosterone we will be doing today. And these will enter the blood. And now they would travel to the different cells and tissues. For example, aldosterone will travel to the kidneys. So this is an axis. So once again, I did it this way because that sometimes helps a student, especially when you start talking about medications and how it interferes with the axis. So once again, the adrenal glands participate in something called an endocrine axis. The name of the axis that the adrenal glands are in is called the hypothalamic pituitary adrenal axis. Consists of 3 different organs that produce hormones. The hypothalamus produces a hormone, CRH, that will influence the pituitary gland to produce a hormone called ACTH. And ACTH will, of course, enter the blood and go to the adrenal glands, where it will cause the adrenal glands to release their hormones into the blood. Now, I'm going to put the hormones here again because we're doing the adrenal glands. So So the hormones that are released into the blood are, for example, cortisol and aldosterone. Aldosterone will be the first one we will do today after we finish all this. So this is a negative feedback system. So meaning if the hormones in the blood go up, the adrenal gland is making too many hormones, that will cause the pituitary gland to decrease ACTH. So this feeds back. This is a feedback system where the pituitary so at this end, if the hormones are elevated, this will then send information back, okay, and the pituitary gland will decrease the production of ACTH, and the hypothalamus will decrease the production of CRH, meaning there's too much. So a negative feedback, remember, with negative feedback, when something increases, the end result is it goes down. In negative feedback, once again, if something decreases, the end result is it goes up. So in negative feedback, the end result is always opposite of what the initial stimulus was or change was. So if your body temperature goes up, the end result is mechanisms to bring it back down. Yeah, your body temperature goes down, the mechanisms exist to bring it back up. I'll give you one more example. If your blood sugar goes up, the body has systems to bring it back down. If your blood sugar goes down, the body has systems to bring it back up. Same thing with our hormones here. If our hormone levels, cortisol and aldosterone, for example, are up in the blood, eventually to bring them down, you will decrease this and decrease this. If our hormones are too low in the blood, there's not enough, then our systems, this will have an increase in ACTH. It's going to try to get the adrenal gland to produce more, and you'll have an increase in CRH. So if the hormones are high, eventually they're going to be decreased. If the hormones are low, eventually they're going to be increased. This is negative feedback. So our endocrine axis operates on a negative feedback mechanism. This is extremely important when at the end, I will briefly, because I want to get through the endocrine system and begin blood and then get to the heart. This is an important mechanism, and when you give medications like steroids, so as future RNs, you're going to be giving steroids to patients. Steroids can wreak havoc with this axis, and while steroids have a lot of beneficial effects, they can also have devastating effects. So we will do that. I just want you to get used to this now. You don't have to worry about this as far as a test until the midterm, but this is a very, very important concept. So we're going to continue with the adrenal glands. We said there are two of them. They sit right above or top the kidneys. They're part of an axis, an endocrine axis called the hypothalamic pituitary adrenal axis. This axis works on a negative feedback system. We are concerned with, so far, CRH, corticotropin releasing hormone, ACTH, adrenal corticotropic hormone, and then the final part of the axis, the adrenal gland, which will release cortisol and aldosterone into the blood. And these are the hormones that will go to the various cells and tissues and exert their various effects. Okay, so I'm going to erase that. Once again, remember this axis. This will make your life much easier when you start giving steroid meds and you start thinking about adrenal gland diseases. So actually, we're continuing with this. So we said two glands sitting above each two kidneys. It's part of an endocrine axis. The adrenal glands are actually two separate glands. And these are, of course, we're going to talk about the adrenal cortex. There's two regions. So the adrenal gland is actually subdivided into two regions, and these two regions are actually two separate types of glands. They secrete different hormones entirely. So the adrenal cortex is the first we're going to do, but the second is the adrenal medulla. So we're going to see the adrenal cortex, which is subdivided into regions itself, is going to secrete certain types of hormones, and the adrenal medulla is another part of the gland that's going to secrete entirely different hormones. So we're going to now, I'll draw it, so we're going to remember the adrenal cortex and the adrenal medulla. Both of these comprise the adrenal gland. So when they talk about the adrenal gland, they're not separating out the cortex and medulla unless specifically they mention the adrenal cortex or adrenal medulla. So these make up once again, the adrenal gland. All right, so once again, the adrenal gland is made up of the adrenal cortex and the adrenal medulla, and these actually secrete two different types of hormones. So we're going to erase this. We're going to do the adrenal gland. I'll draw it quickly. I will go slowly. If the endocrine system is a killer system because there's so many different types of hormones and glands and diseases. They're a major, I mean, you're going to get loads of questions on the NCLEX with the endocrine system because there are so many different types of endocrine diseases. Diabetes is one. So the endocrine gland Here's the adrenal gland. And the adrenal gland is actually subdivided into two general regions. The adrenal cortex and the adrenal medulla. Okay, so the outer region, cortical or cortex means outer layer or outer region. Medulla means inner layer or inner region. So there's the adrenal medulla, the hatch, the black hatch lines it, and the adrenal cortex is the outer region. So adrenal cortex, number one. This secretes steroid hormones. So all the hormones that come from the adrenal cortex are steroids. Other organs in the body that produce steroids, for example, would be the ovaries, the testes, for example, placenta if the woman is pregnant. These are steroid-producing organs. But we're focusing on the adrenal gland right now. So all the hormones that come from the adrenal cortex are steroid hormones. These are called generally corticoids. So why? Because, well, we know it's a steroid. Here it is, oid. And there is cortex. So corticoids, when you hear the term corticoids, whether it's a medication or they're referring to something in the body, corticoids are steroid hormones that are derived from the adrenal cortex. So that's just, and we're going to see there's different types of corticoids. Okay. Also, so these hormones, steroid hormones, need cholesterol for synthesis. So I know cholesterol gets a bad rap in the news, the papers, and these people don't know what the hell they're talking about. You get different companies that, you know, especially with foods, they're pushing this, they're against this. We need cholesterol. It's just we can't have too much cholesterol. So not enough cholesterol, one of the things that will happen, you're not going to make steroid hormones. So all the hormones that come from the adrenal cortex are steroids. They're collectively as a group, these steroids called corticoids. All of these corticoids or steroids require cholesterol for their synthesis. The adrenal medulla. put here. Because we're going to do the cortex. Pardon me, we're going to do the cortex first. So the adrenal medulla, the hatched area, the black lines there, the adrenal medulla is the inner area of the adrenal gland. Once again, the outer region is the adrenal cortex, which secretes steroid hormones. The inner region, the adrenal medulla, is going to secrete another type of hormone. This is actually considered part of the sympathetic nervous system. Actually, I will be, before we actually start blood, and I might do this in the context of when we do the adrenal medulla, that might be next week, I will review the autonomic nervous system in this course, and also because it's so important in pharmacology. So, because of the different receptors and the hormones and neurotransmitters that bind to the receptors, and the drugs that you'll be given as future nurses. So I will quickly just break down the nervous system, and then we're going to just spend some time on the autonomic nervous system, which is probably one of the biggest systems you have to know as far as giving medications, or many medications operate on the autonomic nervous system. So this is considered part of the sympathetic nervous system. This also secretes hormones, and because it's a gland. So if the chemical is released from a gland and enters the blood, it's considered to be a hormone. If the chemical is released from a neuron or a nerve cell, a nerve fiber terminal, it is called a neurotransmitter. If it binds to, it doesn't enter the blood and binds to another cell or membrane receptor. So there is a slight difference, and this is what I think confuses students at times when they're reading the book. Is this a hormone or is this a neurotransmitter? And then everything breaks down. If it's released from a gland and it enters the blood, it's a hormone. So this adrenal medulla is going to release hormones, even though it's part of the sympathetic nervous system. And I'll explain that next week. It still releases hormones that enter the blood. And these hormones collectively are called the catecholamines. And when we do it, I'll do the, where they originate from. And that'll also help you for pharmacology. So in this part here, with the endocrine system, with the adrenal gland and the receptors, there's some overlap with pharmacology. So when I do it in pharmacology, it'll help you here. And when I do it here, it'll help you in pharmacology for those of you who are taking both. So the catecholamines are of course, norepinephrine, second one is epinephrine. And the third is, of course, in small amounts. It's made in the adrenal gland. It's called dopamine. So you are going to see that these steroid, so these are not steroids. Once again, these are biogenic amines. That means they come from an amino acid, and well, write it when we do them, tyrosine. So these are derived from an amino acid called tyrosine. So hence the term amine, right? These all are going to contain a nitrogen group. You're going to hear these all the time. So once again, these are all the steroids, so the adrenal cortex and the adrenal medulla. We're talking about endogenous steroids. These are made by the body. So, for example, the adrenal gland hormones, the steroids, are made by the body. You also have endogenous catecholamines. Once again, made by the body. All right, but also do not forget you as RNs will be giving exogenous steroids. These are medications that are given to the patient. So you can give, there's loads of different exogenous steroids that you will be given to a patient. The patient can take by mouth, they can take by injection, they can apply it topical, they can inhale it. You can place steroids in the eye, you can place steroids in the ears, you can, I inject steroids into joints, into people's joints that have severe inflammation and pain. So, you know the difference. Once again, I did this with you with insulins. You have exogenous steroids, endogenous steroids, and also exogenous catecholamines. Once again, you will be given, as RNs, you will be given norepinephrine. You will be given epinephrine to a patient. You will be given dopamine to a patient. This is so frequent that this is not unusual. This is very, very common, all of this. So you can see there's overlap between physiology and pharmacology. All right, so these are the two regions of the adrenal gland, the adrenal cortex. The adrenal cortex secretes steroid hormones. So all hormones in the adrenal cortex are steroids. They're collectively called corticoids. All need cholesterol for synthesis. The adrenal medulla, the inner region of the adrenal gland, is considered part of the sympathetic nervous system. It secretes hormones that are called collectively catecholamines. So catecholamines are hormones, corticoids are hormones. Corticoids are steroid hormones derived from cholesterol. Catecholamines are biogenic, these are hormones, biogenic and they're derived from the amino acid tyrosine. And they are norepinephrine, epinephrine, and dopamine. So what we're going to do, we got 3 minutes left before our break, we're going to start with the adrenal cortex. So I'm going to erase this. And the first part, before we take a break, I'll list it before I go into it. We're going to do the adrenal cortex. Once again, cortex, cortical, these refer to an outer region, to the periphery. So to give it, so you understand it, because it's used in other contexts. Cortical, this would be the cortical region or the cortex, the outer region or closer to the periphery, right? And then this would be the medullary region or the medulla, the inner region or deeper away from the periphery. So these terms are used with the kidneys. You have a renal cortex, a renal medulla. So you're going to see these terms. You have cortical bone, you have medullary bone. So these terms are used in different areas, in different contexts when you were describing anatomy and physiology. So once again, a cortex or cortical region is the outer region or closer to the surface periphery. The inner region is referred to as the medulla, the medullary region, inner region, or further, deep or further from the periphery. So we're doing the cortex. And once again, we know, because I told you, right, we know this secretes steroid hormones. The corticoids. Okay. The adrenal cortex, I erased it, I don't want to erase it. The adrenal cortex is actually going to be subdivided itself into 3 zones, okay, or areas. So the itself is going to be subdivided. I'm going to use different So if there's an overlap between the zones, we're not doing the histology of the adrenal cortex, so I separated them out for ease of, and they do that in the book also, for ease of memorization. So the first zone, C1, zone 1. Second is zone 2. Third area is zone 3. And it goes all the way up and around, of course. I just did it here. So zone 1 is just, and I'm going to give you the official names. All right, so the adrenal cortex is actually separated into 3 areas or zones or regions. So once again, the adrenal gland is subdivided overall into the adrenal cortex and the adrenal medulla. We're seeing now that the adrenal cortex is a little bit more complex in that it consists of different types of cells that are arranged different ways in 3 zones or areas, 1, 2, and 3. So zone 1, we're going to do the first, I'll list it because we're coming to our break. Zone 1 or region 1 has a specific name. The zona glomerulosa. So this region here, once again, I'm not doing overlap and stuff like that. That region is called the zona glomerulosa. You're going to read about it in books. You're going to hear about it. So what is the zona glomerulosa? It's the first area of the adrenal cortex. This is important, zone 1 or the zona glomerulosa, because this secretes steroid hormones. So this will secrete, of course, steroid hormones. This secretes these steroid hormones are, once again, belong to that group of corticoids. Okay, these are once again corticoids. What is a corticoid? A steroid hormone. That's what they're referring to. But this specifically from this region secretes mineral corticoids. So I'm going to list, we'll do up here. So the adrenal cortex. We know it secretes corticoids. Corticoids are steroid hormones. The first type we're going to do are the mineral corticoids. And the we're not doing, I'm only doing one. We're gonna do the main one, otherwise this course, this lecture, this would take 6 hours, 7 hours alone, maybe longer if I started doing every little bit almost. But the main one you have to know as RNs, or the main one, very important, is called aldosterone. So aldosterone, you've heard of it already. I've mentioned it. It's part of our renin, angiotensin aldosterone axis. Aldosterone is a steroid hormone. It's a corticoid. More specifically, what type of steroid or corticoid is it? It comes under the term mineral corticoids. And so when we do each hormone, I'll list it here under what category for ease to facilitate your notes. Okay, so I will see you in 1/2 hour, and then we'll continue. We're going to do the functions of aldosterone. So I'll see you in 1/2 hour. Okay, welcome back from your break. What we're going to do is going to continue with this. I will let you out about 12 today, so we're not going to be until 12:30, 1:45. I will continue to lecture a little after that, but I'm going to let you out at around 12 o'clock. You'll get the lecture, as I said, about sometime this evening. So we're going to continue with this. This is, once again, can be overwhelming stuff, especially when in pharmacology, when you start really applying this to actual medical conditions and real situations in real life. So we're going to do aldosterone, and that's probably the bulk of what we'll finish up with today. Then that will shift us into the corticosteroids, and we'll be finishing the adrenal medulla. Next gland will, of course, be the thyroid gland, followed by the parathyroids, and the pituitary we're just going to briefly mention, but we will do the posterior pituitary. So we're talking about aldosterone right now. The adrenal cortex secretes these steroid hormones collectively as a group called the corticoids. They're separated into 3 regions or zones, the adrenal cortex. The first is called the zona glomerulosa. The zona glomerulosa, zone 1, secretes, of course, a type of corticoid known as the mineral corticoid. So we have it here on our list. And the most abundant and by far the most important mineral corticoid is aldosterone. Okay, now aldosterone, we're going to do right now, once again, is a very important hormone that's involved in control of sodium, potassium levels, and also the involvement of water reabsorption, a very important hormone in maintaining blood volume. So let's do aldosterone. We're going to do the functions of aldosterone. And that will take us, because the second group of hormones is kind of elaborate, and I will do that. As I said, I'm going to let you at around 12, and I will continue it. I have to take a break, and I have to do something, and then I'll continue lecturing. But you can be out of here by 12. So let me erase this. So once again, the first layer or area of the adrenal cortex is called the zona glomerulosa. The zona glomerulosa secretes the mineral corticoids. So the mineral corticoids are steroid hormones, there are literally dozens of steroid hormones in these different biochemical pathways, and some of them have no activity, some have minimal activity. So there are other mineralocorticoids, for example, deoxycorticosterone, that only has about 3% of the activity of aldosterone. So for us, our purposes, and for future RNs, your primary concern is going to be just not a biochemistry course, the functions of aldosterone. All right, first of all, well, I'll give you the functions first. Or its actions. In some books with hormones, they'll say it's actions instead of its functions, it's actions. That meaning, how does it cause other things to occur? And it's because it's a hormone, so it binds to cell receptors and produces some sort of physiological response. So one important thing is that this hormone will increase sodium reabsorption. So I just put for your notes, when I talk about sodium reabsorption, I mean this is keeping, the body is keeping the sodium. It's not being lost in your urine. So when I say into the body, reabsorption back into the body. It's also increasing water reabsorption. So these two effects right here you should remember, okay, because both of these can lead to an increase in blood volume. And if you remember the relationship, I'll put the box relationship here. Now, there are many factors that influence our blood pressures, that contribute to the regulation of our blood pressure. One of them is our blood volume. And you can see when you have a decrease in blood volume, that will decrease blood pressure. When you have an increase in blood volume, that will increase our blood pressure. So what is the effect of the sodium reabsorption into the body? Na is sodium. Actually, I'll put a charge up there, positive charge. Sodium is an electrolyte. It's also a cation. And water reabsorption. That will increase blood volume. So what will the effect be when you increase blood volume? Of course, that is that will increase our blood pressure. So right away, you should be able to appreciate that aldosterone, a mineralocorticoid, plays a significant role in maintaining our blood pressure. So when our blood pressure drops or we have a decrease in blood volume, for example, severe dehydration, aldosterone will be released to keep more sodium in the body instead of it being in the urine, to absorb more water into the body. Both of these contribute to the increase in blood volume and help bring our blood pressure up. So it would make sense that we also give medications that interfere with aldosterone when somebody has high blood pressure. But right now we're doing the functions of aldosterone. And the third one, which I'll put in red, third function, you got to remember, is that it also promotes or causes potassium excretion from the body. Most of its effects, I'm not going into other organ areas, are on the kidneys. So most of its activity or its actions on the kidneys, I'm not going to talk about sweat glands and the GI tract and other things. So most of aldosterone's actions this will involve the kidneys or the renal system. So the body will keep sodium, keep water, and get rid of potassium. So remember those drugs when we talked about the renin, angiotensin, aldosterone axis. Many of those drugs that you give interfere at that axis and therefore lead to the accumulation of potassium. So you can start to see where this overlaps. So we are doing aldosterone. Most of its actions involve the aldosterone involve the kidneys. It has its actions, these effects predominantly via the renal system. You also aldosterone secretion is controlled. So what controls the release of aldosterone? All right, so aldosterone synthesis pardon me, and secretion are controlled by two main factors. Number one, angiotensin 2, and when I erase this, we'll bring angiotensin 2, and I'll write the whole thing out again. And what else controls aldosterone release from the adrenal gland, the synthesis and release, is to a lesser extent ACTH from the pituitary gland. So this is aldosterone. Once again, this is its functions. Most of the actions, these functions take place in the kidneys. The aldosterone synthesis and secretion is primarily controlled by angiotensin II, which is a product of the renin-angiotensin-aldosterone system. I'll write it in a moment. And ACTH, which comes from the pituitary gland. So we're going to erase this for a minute, but I want you to just remember this for a minute before I do this as a key point. I'm going to erase our adrenal cortex, and I'll put that up again when we do the second hormone, which will be this lecture sequence. But just remember, I'm going to give you the labs now. What you'll see when you have high aldosterone levels and low aldosterone levels. Okay, so key point, I'll put up here, actually I'll put it up here. For the NCLEX and any test. Okay, so the important thing, I'm giving you a major advice. When it comes to the endocrine system and hormones, you first have to know what the hormone does. What is its actions, which I just gave you. Then, diseases that involve the endocrine system and hormones either result in a overproduction or too much hormone, meaning hyper, or there is not enough underproduction of hormone, hypo. So therefore, if it's hyper or hypo, if you know the actions of the hormone, you can start to figure out the questions. You can't figure out the question if you don't know what the hormone does normally. So now I'm going to give you, to help you and save you some pages and pages of reading. If a patient has too much aldosterone, hyper condition, then what are we going to see? First of all, let's check our labs. And when a patient has, so what does the hormone do? It normally increases sodium reabsorption. So therefore, if you have too much of the hormone, your sodium levels are going to be even higher. So when you check a laboratory test, you'll have hypernatremia, high sodium. Okay, what I'm going to erase aldosterone. What else does aldosterone do as far as potassium? We can check. Is aldosterone normally causes the kidneys to get rid of potassium. So now if you have too much aldosterone, that effect will be augmented or strengthened. So when you check your lab, the patient is going to have hypokalemia. A decreased potassium, because that's what it normally does. What else are we going to do about water though, right? It increases water reabsorption. If you may or may not see it, but technically for a test, I'm not going into the clinical subcategories. You may see, of course, if you're retaining water, you're going to see edema. Right? Because what does aldosterone normally do? Causes water reabsorption. Okay, at the flip side, if you have low aldosterone levels or a hypo state, when you check your labs, if aldosterone normally causes sodium reabsorption, now you don't have enough aldosterone, so you're gonna lose sodium, so you'll have hyponatremia. Decreased sodium level, and of course, if the potassium causes aldosterone, I'm sorry, if aldosterone causes potassium loss from the body normally, now you don't have enough, so that means the body is going to retain potassium, so you'll have hyperkalemia. Which is increased potassium. And of course, you're going to have loss of water. And this loss of water can be extreme and can result in extreme water deficit, causing dehydration. And this is a medical emergency. If you're, for example, if your adrenal glands shut down, if you're not making enough aldosterone, this can become so severe it can produce a state of shock. So look what happens when you do the blood volume. Severe water deficit dehydration will decrease your blood volume and decrease your blood pressure. When you decrease blood pressure, now we're going to add on to that so you can start to see this. So let's put this here. A decrease in blood volume can result in a decrease in blood pressure. BP is blood pressure. You need a blood pressure for blood to flow. And if the tissues are not getting enough blood and they're not getting their oxygen, when there's an inadequate blood flow to the tissues, it's called shock. So what is, I mentioned this several times, in Anatomy 1 and with fluid balance, I'm going to erase this here. Let's erase this. All shock is shock. Everybody thinks of shock as loss of blood. Shock, that loss of blood is a cause of shock. Loss of blood is not shock. Shock is so a shock is a state of inadequate tissue or cell perfusion. Perfusion is flow to tissues. That means the tissues aren't getting their blood, which they require. You need oxygen to make energy. So what's going to happen in shock? The cells are going to die. When enough cells die, we will die as an intact organism. So that, once again, there are many causes of shock. I'm just going to tie it in so it'll make sense when we do blood again. One cause of shock is an example. I'm not doing all of it now. An example of a cause of shock. Would be something called hypovolemic shock. Hypo means decrease. Volemic means decrease blood volume. What does emia mean? Emic means pertaining to blood. So hypovolemic shock is going to be is a decrease in blood volume. So what do you think, one of the things you'll see in hypovolemic shock, you're going to see patients' blood pressure is going to drop when you're taking their blood pressure. So hypovolemic shock has two main causes. Of course, the general thing is loss of blood volume, but what does it lead to loss of blood volume? Number one, loss of whole blood. What would be an example of loss of hemorrhage? That's the shock we all think about. Hemorrhage or bleeding. So that's the shock that most people envision when they hear the term shock of patients losing blood. That is hemorrhagic shock, which is a type of hypovolemic shock. Hypovolemia just means decreased blood volume. The other cause of a decreased blood volume is loss of plasma volume. And I did the blood when we did body fluids. We will do blood again, so that will be a good review once I do blood, it'll start to kickstart your memories again when I did body fluids with homeostasis. But a plasma, the fluid part of blood is water, 92% water. So what could cause loss of plasma volume? Example, dehydration. So dehydration is extreme loss of water. And what would lead to extreme loss of water? Severe diarrhea, severe vomiting, severe sweating, burns. Many things can cause the body to lose water and produce a state of extreme dehydration. There's different degrees. If it gets bad enough, your plasma volume is going to go down. You're going to develop hypovolemic shock. So hypovolemic shock, once again, is a decrease in blood volume, either from loss of whole blood, the patient's bleeding, and the second one is loss of plasma volume. They're not losing red blood cells, they're not losing whole blood, they're just losing the plasma part of the blood. There might be a severe deficit of water. Plasma is 92% water. So things that cause dehydration can decrease your blood volume, and you could wind up in shock. So that's one general category of shock. So you can see the importance of aldosterone, because aldosterone maintains our blood volume. So if you have, let's look at this again, low aldosterone levels for whatever reason, you are going to have a loss of water, which can result in dehydration and progress to shock. This is a true emergency. The patient can die without adequate aldosterone levels. So one overall function of aldosterone is to, once again, maintain our blood volume and keep our blood pressure up. Okay, and you can see right here, if your blood, one factor that contributes to blood pressure is the amount of blood you have in your vascular system, our blood volume. So if your blood volume goes down, your blood pressure will start to go down. When blood volume goes down and our blood pressure starts to drop, this is one of the reasons why you take your blood pressure. So if a patient has a blood pressure of 120/80, and they might be bleeding internally, or they're severely dehydrated for whatever reason. And now it goes to you can start to see that blood pressure is going down. And eventually you're going to reach a point where this is a true medical emergency. Because after the top number gets below 90, blood flow will start to slow down. So what's one of the goals in treating this? I would give fluids to do what? Increase blood volume and increase our blood pressure. So as RNs, you're going to be confronted with this all the time. The doctor, you're going to be taking a patient's blood pressure, or the medical assistant and nursing assistant will say, your patient's pressure is usually this over the last 3 days, but now it's this. What is going on? There's a change in this patient's baseline data, and you have to see why this patient's blood pressure is starting to drop. All right. So one cause of a drop in blood pressure would be, of course, a decrease in blood volume. One factor, one hormone that contributes to our blood volume is the hormone aldosterone. Okay, so here's well, I'm going to erase this, but this is good to remember when they start to ask you on a test. A patient with high aldosterone levels will show what lab results. A patient with low aldosterone levels will show what lab results. Or they might be looking for, this is a medical emergency, the patient can die quickly. All right, so I'm going to erase this. We're just going to briefly mention this, and that's what we'll conclude it for you guys and gals. And we still have the other hormones, excuse me, we have the other hormones of the adrenal cortex, which we're not going to do today. So I'm going to erase this. This is big time stuff. And what I did was I tied it into the endocrine system so you can start to see the importance of aldosterone in maintaining our blood volume, because if our blood volume drops, our blood pressure will drop, and therefore blood flow will start to slow up. Okay, so I'm going to erase this. And of course I'm erasing this and we're going to pick it up here. Okay, so we already did the renin-angiotensin axis. I'm not going to go to the whole thing again, but control of aldosterone secretion. That's where we'll do that, and we'll do ACTH, and I'll let you out. And then once again, I said I'll finish up. But control of aldosterone secretion. So there are two general factors. Number one, the renin-angiotensin-aldosterone axis. We already covered this axis, and it'll probably be covered again in pharmacology when we get to the appropriate drugs. If you recall, I gave you loads of different drugs. We did a case with hyperkalemia, and I gave you loads of different drugs that interfere with this axis. But right now, for now, the renin-angiotensin-aldosterone axis is once again another endocrine axis. This is the example I gave you in the beginning of this course. And the renin-angiotensin-aldosterone axis, this results, what happens is, the end result of this is, you produce angiotensin is converted, if you recall I did it the entire axis, angiotensin is converted to angiotensin 1. And then in the lungs, about 70% of this reaction occurs in the lungs. In the lungs, is an enzyme in the pulmonary capillaries of the lungs called ACE. And what is ACE? ACE is an enzyme. This is called angiotensin converting enzyme. Called ACE. You've heard the term ACE inhibitors. I mentioned it. That is part of course pharmacology. The ACE inhibitors are medications that inhibit ACE. I'll give you a couple before we leave, just within a little while. So angiotensin converting enzyme. What does that do? That converts angiotensin 1 to the big guy, angiotensin 2. And angiotensin 2 is a key chemical. So to form this angiotensin 2 from angiotensin 1, you need this enzyme, ACE, in the lung, in the pulmonary capillaries of the lungs, blood vessels. And now this has all these effects. But one big one I want you to know, because we're doing aldosterone, this, number one, increases the synthesis and release of aldosterone from the adrenal gland. So that is one of the functions of angiotensin. That's a result of this axis. It causes aldosterone release. What does aldosterone do? Increases sodium water reabsorption, increases blood volume, and what effect does that have on our blood pressure? Increases our blood pressure. So we're going to see this chemical angiotensin 2. It's a peptide made up of amino acids. This is the result of the renin-angiotensin aldosterone axis. This causes the synthesis and release of aldosterone. This is one of the effects or actions of this hormone on and to produce this aldosterone from the adrenal gland. This also, angiotensin number 2, this is a powerful, and this is where we're going to end it with angiotensin 2 today. This is a powerful vasoconstriction. This causes systemic vasoconstriction. That means the blood vessels, all the blood vessels in the vascular system, particularly the arteries, the arterial side, constrict. And what does vasoconstriction do? We know this increases blood pressure. So you can see the whole purpose of this axis, the main purpose of this whole axis is to maintain our blood pressure. The third thing this will do, it has like a lot, but we're going to do the main ones. It increases ADH release. ADH is antidiuretic hormone. And that will result in a decrease in urine output. What effect will a decrease in urine output? That means you're going to urinate less because the body wants to hold on to water. So what will that do? Increase your blood volume, right? If you're urinating less, you want to maintain your blood volume, and that will increase your blood pressure. So you can see everything is increase in blood pressure. This is also another name for ADH. ADH is also known as vasopressin. Another name for ADH is antidiuretic hormone is ADH. That's not another name. ADH is an abbreviation for antidiuretic hormone. Another name for antidiuretic hormone or ADH, it's also called vasopressin. And when we get the chance in pharmacology, when I do receptors this week, vasopressin works on blood vessels. This causes vasoconstriction. What does vasoconstriction do to our blood pressure? We know that from Anatomy 1. And the last thing, number 4, which is quick, angiotensin. These are the big 4 things that angiotensin does. Number 1, increase synthesis and release of aldosterone. That's our hormone of the day. Number 2, causes systemic vasoconstriction to increase blood pressure. Number 3, it increases ADH levels, antidiuretic hormone, which decreases urine output, increases blood volume, increase in blood pressure. ADH is also known as vasopressin. You're going to be giving vasopressin, some of you, to patients. Vasopressin causes vasoconstriction of our blood vessels, increases blood pressure. One more function of this is number 4. It increases the thirst sensation. And when you're thirsty, if you're dehydrated or you have a losing blood, patients are very thirsty. When you're thirsty, of course, if a patient's confused, you're not going to give them fluid, you're going to give them IV fluids anyway. But that means an increased fluid intake. And of course, course, in the attempt, just like with ADH, reducing your urine output, by increasing fluid intake, hopefully the end result is increased blood volume. And of course, when you increase your blood volume, what do? You increase blood pressure. So in the last 30 seconds, angiotensin II is a very, very important mediator of blood pressure. And how does it do that? It's produced as part of the renin-angiotensin-aldosterone axis. Once it is produced, the enzyme ACE is necessary for that. It will do these four things. There's others, but these are the big four. These will all increase blood volume and increase blood pressure. An example, before we go, of an ACE inhibitor, before you go. This is an example of an ACE inhibitor. What does that do? It inhibits this enzyme. It prills. The ACE inhibitors the generics end in prill. So when you see prill, you know it's an ACE inhibitor. And there's several uses for these drugs, but one use of these drugs, ACE inhibitors, is to treat high blood pressure. All right, they have other uses. I'm not going into them right now, but you can see by giving what's all the results of this system of angiotensin II to increase your blood pressure. So now you give a drug, a prill, an ACE inhibitor, that inhibits this enzyme. So what do you reduce the amount of? Angiotensin II, and therefore what happens to your blood pressure? Your blood pressure will come down because you interfered with the enzyme that participates in the formation of angiotensin II. With that, I will see you next week. I will announce once again on Tuesday, after some of you have taken your pharmacology quiz, once again, the anatomy quiz for this course, Anatomy 2, it's going to be only the quiz. It's going to be emailed to you on Tuesday, and you'll have to have it back by 5 p.m. on Wednesday. So you'll have over 24 hours to complete the quiz, which is only about 25 questions. With that, I wish you well, and I will families well also, and I will see you, most of you, on Tuesday, and the rest on Thursday. All right, have a good week.